Hello and welcome everyone to a new session of clinical pharmacology. Today we are going to speak about pharmacology of respiratory system. Two topics will be covered in this session. Today we are going to speak about clinical pharmacology of asthma and the clinical pharmacology of COPD. COPD stands for chronic obstructive pulmonary disease. Okay, so two topics will be covered in our session today. We are going to speak about asthma and COPD, chronic obstructive pulmonary disease. As you can see here from this slide, um, asthma defined as a reverse chronic airway condition. So we have reversible chronic airway condition characterized by the airway construction, hyperresponsiveness, and chronic inflammation. So the key word here for the asthma, if you compare it with the COPD, is reversible chronic airway condition and associated with the obstruction, associated with the hyperresponsiveness and chronic inflammation. Speaking about COPD, on the other hand, you can see that COPD is considered like reversible chronic progressive obstructive airway disease. That means when the patient start with this disease, there is no return, irreversible. So the situation here to relieve the symptoms, to maybe alleviate the signs for the patient. We don't have a cure for the COPD. So for the COPD, we can see here the purpose for that to reduce mortality and maybe prescribe some bronchodilator, and this case will be fatal. We need to understand asthma. We have three types of asthma. We have mild, moderate, and severe. We have some maybe other category. We are going to speak about that. We recommend the student and the listener audience to review the ACCB chest and American College of Chest Physician, and we have the YouTube link for more information. Okay, starting with asthma is very important in order to understand or to apply the best pharmacological treatment for asthma. We need to understand pathophysiology. What happened in asthma when the patient starts suffering from asthma? What happened inside the respiratory system? As you can see here from the graph, we have allergens, inhaled allergens. These allergens will maybe attach to the epithelial cells in the bronchial tree, and this will release stem cell factors, and this stem cell factors will stimulate another cell called mast cells. So when the allergen attached to the epithelial cells and moving to the mast cells, you can see the allergens here, allergen particles bind to the IgE on the mast cell surface. This is number one. Number two, also the allergen bind to the dendritic cells. So we have two type of cell, mast cells and dendritic cells. Okay, so what happened next? You can see here the mast cells also able to activate the dendritic cells. Number one. Number two, the mast cells are also able to release content in the next step. So dendritic cells here, when the allergen bind to the dendritic cells, this will lead to the activate some type of lymphocyte called T helper cells, and activation of T helper cells will lead to the activate two pathway. Number one will activate B cells, B lymphoid cells, and will activate or induce as eosinophil. Eosinophils, when the eosinophil induced or activated, this will maybe cause inflammation or like cause of fighting between the exogenous harmful substances and endogenous substances. So the main cause will be inflammation here. So as you can see here, we have so many cells, multiple cells involved in the asthma. Number one, we have the mast cells. Number two, we have epithelial cells, mast cells. We have dendritic cells. Then we have T cells, B cells, and eosinophil. So all these factors may be involved in the asthma. Okay, so what we have here, when the allergens bind to the asthma, this will lead to something called degranulation. The content of the mast cells will be released. As you can see here, the content of the mast cells will be released to the circulation, to the local tissues. So the mediators could be mainly histamine. We have some prostaglandin and other leukotriene. So the effect of these three mediators on the bronchial tree will be bronchoconstriction, and you can see the bronchoconstriction in this image. This is the healthy normal airways, and this is the asthmatic airway during attack. Okay, so this number one, the histamine cause bronchoconstriction. The histamine stimulate eosinophil. Eosinophil participate and involve in induce inflammation. So we have bronchoconstriction, and in addition to the inflammation, this will lead to the increased production of mucus. Okay, so for pathophysiology, as you can see, we have chronic inflammation, we have a bronchoconstriction, and we have increased mucus. So our target will be maybe towards these variables like decreased inflammation, enhanced bronchodilation, and decreased mucus production. Okay, moving to what happened next. We know that if you go back again to this cells, for example, here, if you look on this cells here, we have something also. We have. Let me open the whiteboard. Okay, so from the whiteboard here, if you look on the bronchial tree here, we have something called, in the inner part, we have endothelial cells here, endothelial cells, and this is the endothelial cells, and then we have the membrane. This is a basement membrane, and this is endothelial cells. Okay, on the other maybe outer side, on the outer side, okay, we have something called smooth muscle cells. Okay, so you can see the component for the bronchial tree here. If you look on the bronchial tree in this way, for example, so you can see endothelial cells, we have basement membrane, then we have smooth muscle cells. I will go back again to the image. We have it there. Okay, so what we have here, you can see. Okay, now we have the endothelial cells, and we have the epithelial cells release histamine, and also adenosine will be released. Cell membrane will be activated through an enzyme called phospholipase A2. So this will lead to the activate of arachidonic acid. So we have three main mediator will be activated when we have degranulation. You can see that degranulation release of the mast cells content here. So when the mast cells content release their content, what happened there? Number one, activate arachidonic acid. This will lead to the activation of leukotriene and prostaglandin. Leukotriene through the lipooxygenase, LOX lipooxygenase, and cyclooxygenase COX stand for cyclooxygenase. This is responsible for prostaglandin synthesis. Okay, so again, three main mediators. I will repeat it. Three main mediators will be released and activated when we have antigen bind to the IgE. Okay, bind to the IgE. This will lead to the activate and release histamine. Number one, increase or activate adenosine, and arachidonic acid leukotriene will be activated. So 1, 2, 3 mediator will be released during the allergic reaction. Okay, I will start with the first mediator. We call the first mediator histamine. Histamine released, then we have another, and on the other side here, in the like paracrine, we call this one paracrine or paracrine. Okay, so what we have here, this is the adjacent cells, the smooth muscle cells. You see the smooth muscle cells here. So in the smooth muscle cells, we have receptor. The histamine bind to the H1 receptor, histamine 1 receptor, and this will lead to the activate GQ receptor, and the end result will be increased calcium concentration inside the cells, and the result will be smooth muscles contraction, and the result will be bronchoconstriction here. Okay, so you can see here histamine bind to the H1 receptor, activate GQ, increase calcium, and this will lead to the contraction of smooth muscle in the bronchial tree. This is number one. Moving to the another mediator, and this mediator called leukotriene, LTS for abbreviation. And this is this mediator may be formed due to the activation of arachidonic acid through the enzyme called lipoxygenase, LOX. Okay, leukotriene bind to the leukotriene receptor in the smooth muscles, activate GQ protein, increase level of calcium, lead to the contraction of smooth muscles, contraction of bronchial tree. Okay. Next, we have another mediator called adenosine. As you can see here, adenosine in the image here, adenosine bind to the adenosine receptor 1 on the smooth muscles. Adenosine will activate GI protein. I here stands for inhibition effect or inhibitory effect. So adenosine bind to the GI protein, G inhibitory effect. This will lead to the something called like decreased cyclic AMP, and this will activate contraction of smooth muscles. So we have now three mediators involved in the contraction. Number one, histamine cause contraction. Number two, leukotriene cause contraction. Number three, adenosine cause contraction through the GQ and GI respectively. Okay. Moving to the next mediator involved in the bronchial constriction, acetylcholine or acetylcholine. Acetylcholine bind to the M3 receptor in the smooth muscle in the bronchial tree. Okay, this binding to the M3 receptor on the bronchial tree activate GQ protein, will lead to the increased concentration of calcium and contraction. Okay, so this is all these mediator. We have four main mediator. We need to remember this mediator with you and summarize the information. So the question now for us: which mediators may be involved in the bronchial constriction? So histamine cause bronchial constriction, leukotriene cause bronchial constriction, adenosine cause bronchial constriction. On the other side, we have epinephrine, norepinephrine. Epinephrine and norepinephrine bind to the B2 receptor. B2 receptor activate GS protein, increase level of cyclic AMP. This will lead to the relaxation, smooth muscle relaxation. We have already discussed what happened with asthma, so I will go back and remind everyone what happened in pathophysiology of asthma, which mediator will be involved in pathophysiology of asthma. As you can see from the beginning here, we have several types of cells will be involved in pathophysiology of asthma. Number one, we have mast cells, we have IgE, immunoglobulin E, we have eosinophil, we have B cells, T cells, helper dendritic cells. All these maybe cells will be involved in asthma. And then we move to the what happened there. We have the connection between the smooth muscle cells and endothelial cell and mast cells, and you can see here mediators, four mediators, 1, 2, 3, 4 mediator cause bronchoconstriction, and only one mediator cause bronchorelaxation. Beta-2 receptor activate, beta-2 receptor cause bronchorelaxation. On the other hand, acetylcholine, histamine, adenosine, leukotriene cause bronchoconstriction. Okay, moving to the next topic now. Speaking about as chronic obstructive pulmonary disease, COPD pathophysiology. The main cause of COPD, cigarette smoke irritant, or we have another rare case called alpha-1 antitrypsin deficiency, it's like genetic cases. But the most popular cause will be cigarette smoking irritant. So the cigarette smoking irritant, when you have it like chronic smokers, this will activate macrophage, this activate monocyte, and neutrophils. All these cells will be activated. When these cells are activated, these cells start producing something enzyme called protease enzyme. The protease enzyme responsible for production of mucus and also for the destruction of the cell wall. So you can see here alveolar cell wall. So we have mucus production and destruction of cell wall. Also, this will lead to the activate T cells, T lymphocyte. The fibroblast cells will be engaged and cause fibrosis. When you have fibrosis and mucus destruction, this one considered like irreversible. So this change here in the bronchial tree irreversible, but we need to remember what type of cells will be involved in the on the COPD. We have macrophage, monocyte, neutrophils, T lymphocyte, fibroblast cells, and cause fibrosis. Fibrosis is not available in the asthma, only in the COPD. Okay, roughly we're done with the pathophysiology. We spoke about pathophysiology, but what we have here. Okay, so what we have here, you can see we have target for us. If you go back, for example, to previous slide here, okay, we start thinking about, okay, what we can do, what medication we can use it for our patient here, for example. I put it in the green color. So we can use something to block adenosine. We can use medication to block the histamine. We can use medication to block the leukotriene, to block the acetylcholine, or we can use something to stimulate beta-2 receptor. All these will be target for us. So next we are going to speak about medication used to treat asthma and COPD. Okay, first of all, you have the first group here, medication work on beta-2, and this one will be agonists. We are speaking about agonists. That means this medication able to stimulate. You can see the plus here. So beta-2 adrenergic agonists stimulate beta-2 receptor, increase cyclic AMP S, increase protein S and cyclic AMP. This will lead to the relaxation. We have two types of receptor. We have two types of agonists. We have short-acting agonist, then we have long-acting agonist. Short-acting agonist, abbreviation for that, SABA. Long-acting agonist, long-acting beta-agonist, the abbreviation LABAs. So we have SABA and LABAs. For SABA, we have albuterol, levalbuterol. For long-acting, we have formoterol, philanterol, and salmeterol, long-acting once or twice daily. Okay, moving to the muscarinic receptor. If you block the muscarinic receptor, we are going to use something called antagonist. So when you block a muscarinic receptor, the result will be relaxation, because if you activate it, the result will be contraction. So if you activate muscarinic receptor, will be activation. What happened if you block the muscarinic receptor? The result will be relaxation. Okay, so we have two types. We have SAMA and LAMA. For SAMA, we speak about short-acting muscarinic antagonist. Short-acting muscarinic antagonist, SAMA. One medication in this list, abratropium, and tropium coming from atropine, abratropium, short-acting muscarinic antagonist. Then we move to the long-acting and muscarinic antagonist. We have LAMAs. We have tiotropium, aclidinium, and dumeclidinium. So we have two groups of medication. Could be used for asthma, could be used for COPD, beta-adrenergic agonist, muscarinic antagonist, and we discussed the group of medication. Okay, this list here is perfect. So we need to understand what happened in this list here. Okay, So as you can see here, we have all these square here, like represents medication used for asthma or COPD. We can use beta 2 adrenergic. We can use beta 2 adrenergic agonists, such as albuterol. For example, if you go back, we have this beta 2 and adrenergic agonist, could be SABA and LABA. Okay, beta 2 adrenergic agonist, number one. We can use muscarinic antagonists, such as ipratropium. Okay, what about leukotriene? We know that leukotriene causes bronchoconstriction. What happens if you block the leukotriene receptor? We have leukotriene receptor antagonist, montelukast, staphylococcus. Then they said, what happened is that if you block the lipoxygenase? We can use lipoxygenase inhibitors, so we have Zoliton. So regarding the anti-leukotriene drugs, we have two groups of medication there. Number one, we have medication affect the receptor. We call this one leukotriene receptor antagonist, and we have another medication, a black lipoxygenase enzyme, Zoliton. So the question now for everyone, which of these anti-leukotriene block the lipoxygenase receptor? So the answer will be Zoliton. Which of these anti-leukotriene drugs block the receptor? So the answer will be montelukast and zafirlokast. Okay. Moving to the medications, for example, here, can we use antihistamine? Could be used, but not the first line treatment. We can use antihistamine to relieve symptoms, but not the first line treatment for asthma. Moving to the corticosteroid, yes, corticosteroid used for asthma, inhaled corticosteroid, ICS. Corticosteroid inhibits phospholipase A2. Okay, this is a mechanism of action. What about amilozumab? Amilozumab monoclonal antibody, here you can see it. Amilozumab bind to the IgE and prevent immunoglobulin for binding to the site on mast cells. Amilozumab, this one injectable, available like injection medication. Okay, moving to the last two medication on the list here, we have thiophelin. This is old medication with a narrow therapeutic window, narrow therapeutic index, and it's not in the guidelines anymore. Thiophelin, and as you can see, thiophelin work in two mechanisms. Number one, thiophelin inhibit adenosine receptor. This is the adenosine receptor. So thiophelin inhibit adenosine receptor, number one. Number two, thiophelin inhibit phosphodiesterase 4. So we have two mechanisms for thiophelin in asthma. Number one, inhibit adenosine receptor. Number two, inhibit phosphodiesterase 4 in the smooth muscle cells. And now we have in a group, maybe, or medication belong to the similar group, but it's like more selective. And this is oral medication, roflumilast. Roflumilast, as you can see here, they said we don't need to work on the adenosine. We try to develop medication work only on phosphodiesterase, inhibit phosphodiesterase 4, and they developed roflumilast. Roflumilast considered like phosphodiesterase inhibitor 4, selective for this enzyme, roflumilast. So from this list here, we can review it together. Now, number one, first group, beta 2 agonist. Second group, muscarinic antagonist. Then we have leukotriene antagonist. Then we have omilozumab, antihistamine, corticosteroid, and at the end we have phosphodiesterase inhibitor. So all these medication on the table for treatment asthma and or COPD. For corticosteroids, so we're done with the classification. Okay, this slide here represents the corticosteroid, and we discussed that corticosteroid work through the inhibitory effect on the phospholipase A2. So corticosteroids inhibit phospholipase A2 enzyme, and this enzyme responsible for formation of arachidonic acid. And then we have two pathways, but we focus on lipoxygenase mainly. So the main mechanism of action for corticosteroid will be inhibit phospholipase A2. Medication available for that, we have inhaler corticosteroid. So we call this one inhaler corticosteroid. Then we have systemic oral or could be injectable medication. So we have two options here, could be oral or injectable medication. Speaking about inhaler, we have beclomethasone, we have budesonide, we have cyclosinide, fluticasone, mimetasone, triamcinolone. All these medications prescribed orally, inhaler, sorry, beclomethasone, budesonide, cyclosinide, fluticasone, mimetasone, and triamcinolone. For the oral and systematic, we have systemic, we have dexamethasone, we have methylprednisolone, prednisone, and prednisolone. So we have less of medication for oral. It's already covered in other lectures. So all these medication and inhaled cortisone considered like first line treatment for asthma. Here we speak about patients from chronic asthma. We place the patient on the inhaled cortisone. Okay, so we discuss how the corticosteroid agent or corticosteroid drugs. Now we start looking on the actions. So what happened if the corticosteroid inhibit phospholipase A2? What happened there? So we look corticosteroid inhibit phospholipase A2. Then what happened? What is next? So you can see here corticosteroid considered like the most effective anti-inflammatories for the treatment of asthma. So please remember the main action for the corticosteroid, the anti-inflammatory effect. So the main action will be anti-inflammatory effect of cortisone. So anti-inflammatory effect decrease this here maybe explain the mechanism of action. Number one, decrease inflammatory genes, increase anti-inflammatory genes, increase beta-adrenergic receptor. This is very important things. Increase number of beta-2 adrenergic receptor. Also, they found corticosteroid improve response of beta-2 receptor stimulation. So number one, increase the adrenergic receptor, the adrenergic beta-2 adrenergic receptor, increase the number of these receptor, increase responses of these receptor. Okay, moving to the next, decrease mucus production and decrease bronchial hyperresponsiveness and decrease edema. All these like beneficial effect of cortisone. Decrease inflammation, enhance anti-inflammatory gene, increase number of beta-2, increase number response of beta-2 receptor, decrease mucus, decrease inflammation, and decrease airway edema. And we have here some suppression genes involved in the asthma, and cortisone work on these genes such as cytokine TNF alpha and interferon, interleukin, several type of interleukin. So we done with the maybe discuss the pathophysiology of asthma and COPD, and then we discuss the medication used for asthma and COPD. Now we move to the asthma goal of therapy. So here we are speaking about asthma. Number one, the goal of therapy to prevent airway inflammation. Reverse. So in the COPD, we don't have reverse because like the case in COPD, irreversible. With asthma, we have the ability to reverse the inflammation. So in asthma, the goal of therapy reverse and prevent airway inflammation. Number two, decrease and alleviate symptoms here. Number three, prevent exacerbation and minimize limitation in activity. So all these will be considered like goal of therapy for asthma. At this small break of this lecture, we recommend everyone to like and subscribe to this channel. It's highly recommended and really appreciated. Thank you so much. Okay, this slide here demonstrate the goals of therapy. You can see here according to classification, we have four main type of asthma. We have intermittent asthma. Okay, so we have intermittent asthma. Then we have mild persistent asthma, moderate persistent asthma, and severe persistent asthma. According to the how much we need the short acting short-acting beta-agonists. We call this one SABA, such as albuterol, for example. If the patient suffer from, if you speak about the first one, first type of category, intermittent, patients suffer from bronchoconstructive episodes less than 2 days per week. The spirometry or the peak flow near normal. In this case, if we have less than 2 episodes per week, no need for daily medication. But we recommend patient to use short-acting agonists like SABA as needed. Okay, so when you have less than 2 episodes of bronchoconstriction per week and the spirometry normal, no need for medication, use SABA as needed. This is the first one. Moving to the second one, the patient here in the mild persistent, the patient suffer from more than 2 episodes of asthma or like bronchoconstriction per week, but not daily. So 2 days could be 2, 3, 4, but not every day. The lung function, the spirometry function, peak of flow function is normal. Here we start with the low dose of inhaled cortisone, inhaled corticosteroid, low dose. And we use short-acting as needed to relieve symptoms. So remember the short-acting used to relieve symptoms. Okay, so the regular daily use will be low dose of inhaled cortisone for persistent when the patient have more than 2 episodes per week but not daily. The lung function is normal, spirometry is normal, above 80. Moving to the moderate persistent here, you can see the patient suffer from daily bronchoconstriction, daily episodes of bronchoconstructive every day. The patient suffer from bronchoconstriction every day. They look on the peak flow of spirometry, the spirometry between 60 to 80 of normal. How we can deal with this patient here? We have two options. We move the inhaled cortisone from low dose to the medium dose. This is one option. Increase the dose of inhaled cortisone, one option. Or the other option, keep the low dose of inhaled cortisone and we add LABA. So you can see here, patients suffer from moderate persistent, daily episodes, lung function between 60 to 80. We increase the dose, escalate the dose from low to medium dose of inhaled cortisone, or other option, keep the low dose of cortisone and add LABA. Here also they insist we start using the short-acting beta agonist like SABA here as needed. Okay, moving to the severe persistent here, the patient suffer from continual severe persistent, the patient suffer from continual the patient suffer from continual episodes here, like day and night, not only per week, is like continuous during the days, during the time. The lung function less than 60%, the peak flow less than 60% on spirometry. Here we have two options. Number one, we escalate the dose of medium inhaled cortisone to the high dose cortisone plus LABA. This is number one. Or keep it like medium dose plus LABA. So what we have there, keep the patient on medium dose and add LABA. If there's a response, that's fine. If no response, we move to the escalate the dose of inhaled cortisone. So we have in the severe persistent, we need to add LABA in addition to the inhaled cortisone. Okay, the question here, how do we know low dose, medium dose, and high dose? We have three medications here. We have beclomethasone inhaler, then we have budesonide inhalation, then we have fluticasone meter dose inhalation. Here we need to be familiar with these doses. For example, we have low dose. For example, here it's not available for children between 0 to 4 years. But if you look on the children between 5 to 11 years, we have low dose, we have medium dose, we have high dose. The same apply for adult or above than 12 years old. Low dose, medium dose, high dose. Here we don't expect maybe people to remember all these doses, but this one will be available on your website, on your electronic device. So when you have patient, for example, between 5 to 11, and you need to place your patient on low dose, you are going to choose 80 to 160. Okay, the same will be applied to the fluticasone, for example, children between 0 to 4, low dose, medium dose, high dose. Okay, if you need to know more about the taking a spirometry test, if you need to know more about taking spirometry test, you can visit the website for NIH here on YouTube, or this visit here on the teaching us the methods how to measure the FVC or FEV1. I would recommend you to go to this website and watching the YouTube. Okay, medication used for asthma, we already discussed with you. We have beta-2 agonist. Then we have muscarinic 3 receptor antagonist. Then we have leukotriene antagonist. Then we have omalizumab. Then we have thiophelin. Then we have roflumilast. So we have a group of medication. We can discuss it together. So the first group of medication here in this slide, we are speaking about the beta-2 agonist. But for beta-2 agonist, we have short-acting, and we have long-acting. They remind us the short-acting albuterol, phentoline, for example, and levalbuterol. This medication prescribed inhaler. This medication prescribed inhaler. Okay, to provide a quick relief of symptoms. This medication start after 5 to 30 minutes and remain for 4 to 6 hours, and provide the quick relief of symptoms of bronchoconstriction. So when you use this inhaler, they start in a few minutes and remain for 4 to 6 hours to relieve symptoms. This medication could be used monotherapy for mild and intermittent, and if the patient suffers from exercise-induced asthma, we use it as monotherapy. This medication, SABA, could be used in adjunct in moderate, persistent, or severe asthma. So if you go back to this table here, you can see here we have short-acting plus in cortisone, we have short-acting plus LABA. So it could be used in like a combination, or could be used alone. Could be used alone as monotherapy for mild, intermittent, but if you have moderate or severe, we use it as combination therapy. So beta-2 agonists, we have two medications. We need you to be familiar with these two medications. We have albuterol and phentoline and levalbuterol. Speaking about long-acting beta-2 agonists, so we have LABA. So the first slide we have SABA, then we have LABA. LABA stands for long-acting. We have salmeterol and formoterol. Provide prolonged bronchodilation, lasts for 12 hours. And this group of medication used for moderate to severe. We don't use it for intermittent and like mild. We use it only for moderate and severe asthma. Use the monotherapy is contraindicated. We don't use it alone as a monotherapy. It should be with inhaled corticosteroid. So LABA should be with inhaled corticosteroid. Okay. So beta-2 agonist, this diagram here to summarize the information for beta-2 agonist. You can see here we have short-acting, then we have long-acting. They remind us with the short-acting, we have albuterol, SABA, terbutaline. So for short-acting, we have albuterol and terbutaline. For the long-acting, this one used in severe asthma in combination with the cortisone. Please remember that. So we have 4 medication. The first 2 used twice daily, every 12 hours. We have formoterol and salmeterol every 12 hours. Then we have once daily, long-acting, the half-life more than 24 hours. We have filantrol and olidaterol. So we have philantrolol and oladeterol. So the question here, which of the following medication considered like long acting and given once daily? So we have philantrol and oladeterol. Which of these medication prescribed as needed? Okay, albuterol. Which of these medication prescribed twice daily? Formoterol and salmeterol. Any side effect for beta agonist? They said, okay, yes, beta agonist may cause skeletal muscle tremors due to the direct effect on skeletal muscle. Beta 2 agonist, skeletal muscle tremor. Tachycardia, affect the beta 2 and the atrial. Hypokalemia, mean decreased level of potassium in the blood. Hypokalemia, the beta 2 that have direct effect on the uptake of potassium by the skeletal muscle. The result will be hypokalemia. Restlessness and metabolic effects such as increased level of glucose, pyruvate, lactate, and insulin. So this is a maybe side effect of beta 2 agonist. I will repeat it. We have patients may suffer from skeletal muscle tremor, tachycardia, hypokalemia, restlessness, and metabolic effect. Okay, so we're done with the first group of medication. We spoke about beta 2 agonists. We have short acting, long acting. And we spoke about the side effect of this medication, such as hypokalemia, such as muscle tremor, tachycardia. What about the next medication, next type of medication? So the first type we spoke about SABA and LABA. Okay, this is the first group of medication. Then we have corticosteroids here. Okay, corticosteroids. How this medication work? Corticosteroid considered drug of choice for long-term treatment in persistent asthma. So if the patient suffers from persistent asthma, we can prescribe corticosteroid. Corticosteroid inhaler corticosteroids could be used on a regular basis, but this medication take time to start effect. How the corticosteroid work? Okay, the mechanism of action for corticosteroid, number one, the most important step, inhibit phospholipase A2. Inhibit phospholipase A2 and decrease release of arachidonic acid. And the corticosteroid decrease inflammatory cascade, reduce hyper responsiveness of the airways. So these are important things. And the main effect for cortisone, decrease or inhibit or reduce inflammation. And remember, with in asthmatic people, the patient suffer from three characteristics. Number one, the patient suffer from bronchoconstriction. Number two, the patient suffer from increased secretion of mucus. Number three, the patient suffer from inflammation. So our medication inhibit inflammation, cortisone. There is no effect on the bronchoconstriction or on the mucus. Medication available, we have beclomethasone, budesonide, fluticasone, memetazone. So you can see the medication name again: beclomethasone, budesonide, fluticasone, memetazone. This medication prescribed inhaler and considered like first line treatment. Reduce when you prescribe it inhaler, we avoid the systemic effect of cortisone, because it's like local effect here. When we talk about local effect on the lungs, and there is less systemic effect. For example, here Cushing syndrome, we avoid Cushing syndrome here. For example, inhaled cortisone, inhaled corticosteroid, consider like first line treatment for patients suffer from asthma. What type of asthma? So if the patient comes to the clinic suffer from, or to the emergency room, persistent asthma, so the first medication will be prescribed first line therapy. Here we need to remember, if you go to the table, We have medium dose, and if there's not enough response, we move to the high dose. If there's no response, we add LABA, long-acting beta blocker, if you move to the table here. Okay, this medication, so inhaled, first-line therapy, oral, systemic, prednisone, methylprednisolone. This is used on patients suffer from severe exacerbation as a last option if symptom uncontrolled by inhaled. So we prescribe inhaled cortisone, but there is no response. We can prescribe oral or injection cortisone if the inhaled failed to produce the effect. Adverse drug reactions, the patient may suffer from oropharyngeal candidiasis and hoarseness. Okay, so for local inhaled cortisone, we have oropharyngeal candidiasis and hoarseness. But on the other hand, when you prescribe the cortisone systemic, like oral or injection, there's a risk of osteoporosis, risk of hyperglycemia, risk of hypokalemia, risk of hypertension, risk of peripheral edema, risk of glaucoma, immunosuppression, increased appetite, susceptibility to the infections. So all these risk factors for cortisone, and we need to explain why cortisone causes all these effects, and this should be covered in the lecture about corticosteroids under the adrenal cortex hormone. Okay, so we're done with the second group of medication. We already discussed the beta-2 agonists, the first group beta-2 agonists, and we have short and long-acting, short-acting. Then we discuss the corticosteroid. We have inhaled corticosteroid, then we have systemic. Okay, moving to the third group, leukotriene, anti-leukotriene. Okay, so for anti-leukotriene, we have two types also. Okay, we have Zolitone, we have Zafirlocast, Montelocast. Zolitone inhibit the enzyme. So Zolitone inhibits the enzyme called leukoxygenase. Then we have Montelocast, Zafirlocast. This one inhibit leukotriene receptor. So we have two types of anti-leukotriene used for patients with asthma. The first one inhibits the enzyme called leukoxygenase, the medication named Zolitone, and the other two medications, Zafirlocast, Montelocast. This medication inhibit or block the leukotriene receptor. This medication decrease inflammation, decrease arterial constriction, and decrease mucus production. Leukotriene is like second line treatment. So the question, what is the first line treatment for the patient? What is the first line treatment for the patient? For asthma, first line treatment will be inhaled cortisone. Second line, leukotriene. This medication could be used to prevent asthma symptoms, to prevent exercise-induced asthma. Some patients may suffer from increased liver enzyme or headache, dyspepsia. So this may be considered like side effect of anti-leukotriene. Okay, next we have another group of medication, Cromolyn sodium. Cromolyn sodium, this group of medication stabilize the mast cells membrane, inhibit mast cell degranulation, and inhibit release of histamine. This medication used for prevention, okay, more for prevention, more than for the treatment. So we have the mast cells here. Okay, the mast cells here. Okay, then this medication stabilize, come to the cell membrane and stabilize cell membrane. And you know that we have inside the cell membrane, we have granules. Okay, and by stabilizing cell membrane here, they don't allow the granules to leave. So they don't allow. So in this case, inhibit degranulation and inhibit release of histamine. Could be used for mild persistent asthma. Short drug of choice, maybe limited use for this medication. We don't recommend to use it. It's used for prevention orally more than treatment. Then we have to we need to talk about cholinergic antagonist. Cholinergic antagonist, here we talk about muscarinic antagonists. Muscarinic antagonists. Okay, we have also short acting, long acting. So when we talk about short acting muscarinic antagonists, SAMA, then we have long acting muscarinic antagonist, LAMA. So we have SAMA and LAMA. Okay, short acting, we have ipratropium. So the ipratropium, the question here, what is ipratropium? Short acting muscarinic antagonist, use inhaler for patients suffer from asthma. Short acting, so used for asthma, COPD, or asthma COPD overlap syndrome. Could be used for SABA, could use emergency room, and when the SABA not related, we use LABA, SAMA. So this one here, the situation, we start with the SABA, and patient unable to tolerate SABA, we move to the SAMA, short acting muscarinic antagonist. Moving to the next group of medication, we call this one LAMA. Long-acting muscarinic antagonist. We have tiotropium, we have other medication. Add on in adults with severe asthma and history of exacerbation, LAMA. Patient may suffer from xerostomia and beta tests. Again, if you remember, if you go to the table how to manage, so if the patient suffers from severe asthma, persistent asthma, exacerbation, this patient, when you come to the clinic with severe exacerbation asthma, this patient here with a severe asthma will be already on short-acting beta-agonist, and this patient will be already on inhaled cortisone. This patient will be already on LABA. Or if we don't have control on asthma, we can add LABA here. LAMA, like tiotropium. Okay, next next medication here, we spoke about the beta-2 agonist. Again, we already talked about the cortisone. Third one, we spoke about leukotriene antagonist, Cromolyn sodium. Then we have SAMA and LAMA. Okay, moving now to the next group of medication, methylxanthine. Methylxanthine, the medication name thiophelin oral, aminophylline IV. So we have two medication, oral or IV. This medication used for patients who are from asthma, chronic asthma, as bronchodilator. This two medication has been replaced by beta-2 agonist and cortisone, inhaled cortisone. Why? Because the thiophelin, aminophylline considered like narrow therapeutic index. This is the reason. Replace it by beta-2 agonist and cortisone inhaler. This methylxanthine requires drug monitoring. This medication causes adverse drug reactions and numerous drug-drug interaction. How this medication works? Two mechanisms. Number one, inhibit phosphodiesterase, the first mechanism. And the second mechanism, antagonize effect of adenosine. If you go to the, here we recommend you to review the picture or the image in previous slide. How thiophelin work? We already have it in the picture if you remember that. They found methylxanthine has additional anti-inflammatory effect, therapeutic range between 5-15 milligram per liter, not recommended for regular use due to the narrow therapeutic index, and we are familiar with this one here with the narrow therapeutic index. A patient may suffer from nausea, vomiting, headache, and diuresis. This medication may cause seizure. This medication may cause cardiac arrhythmias. For this reason here, for the last two side effects here, the seizure and cardiac arrhythmias, we don't recommend to use this medication as a first choice. So we don't have it in the practice as a first choice. But here we need you to remember we have two medication. The first one, it will be available oral thiophelline, and another one available IV aminophylline. But this medication has narrow therapeutic index. This medication works on two mechanisms. Number one, phosphodiesterase inhibitor. Number two, antagonized adenosine mediator. Okay, monoclonal antibody. This is the last one. You can see it available like injection Xolair. Monoclonal antibody used for severe persistent asthma, poorly controlled by conventional therapy. So you place the patient on conventional therapy. For example, you prescribe albuterol. As needed, BRN as needed, plus inhaled cortisone, high dose, plus LABA, and at the end we prescribe LAMA, and the patient still suffer from continuous symptoms. They said, okay, we can place the patient on omalizumab. And how this medication work, bind to the IgE immunoglobulin E and inhibit the immunoglobulin E. So we have it also. I prefer to review the image. Okay, we have another group of medication. Omalizumab bind to the immunoglobulin. We have a group of medication now. Mepolizumab, benralizumab, risuzumab. This is considered like interleukin-5 antagonist. Use is limited due to the cost. Very expensive medication. Route of administration injectable, in addition to the side effect. Okay, thank you for listening. We already covered the asthma pharmacology, and this is ended up our session for today about clinical pharmacology of asthma. And the next session about respiratory system will be chronic obstructive pulmonary disease, pharmacology, and clinical pharmacology. Stay tuned and have a great day, everyone.